The whole session is dedicated to RH negative public demand. And the public number one was Dr. Rajul Singh. So I thank you all for joining and then pushing us to do this presentation. In our routine antenatal care, we definitely do these investigations. Please, at least one senior, there are many senior resident, and anyway, one single junior resident. So at least they should know that we should not forget these antenatal investigation. That's a must before ordering for high funda test like NIPT or serum screening. They are optional tests, but these are definitely has to be done, and blood group comes top on the list. So RHD negative, you will find 5% of the population. So suppose you are seeing 100 women in your antenatal clinic, 5 of them will be RH negative. Because 95% are RH positive, so many of their husband will be RH positive. And the chances of developing antibody in them is 15%. Prophylaxis of this condition is available, and hence we can prevent it. Like something like polio eradication or eradication of a disease. But if not eradicated, we can treat them and we can have a fruitful outcome of the pregnancy. So today we will be passing through this all throughout till next 2.5 hours. We will be dedicating to RH negative. Once you get a blood group of RH negative, you start thinking what is to be done. Then you get a ICT done or indirect Coombs test done, and sometimes the reaction becomes like this. And if you get a fetal high drops, then you do like this. But probably, let's figure out what is to be done, and then all throughout the reaction is to be a normal reaction that is seen in any other pregnancy. So all of us were in that era where we wanted a negative report, COVID negative, COVID negative, negative. And then let's turn it into positive. That means from negative, let's move on to some amount of positive learning in this case. So we move on, and we move on to get this answer. So this will be the objective of this today's session is case-based discussion. All cases, nothing, no theory. It is only case. So everything is started with a case. This will be RH negative non-isoimmunized pregnancy. How do we monitor? RH negative isoimmunized pregnancy who has got a less than critical titer or more than critical titer. Then subsequently, we have a case of RH negative hydrops fetalis. There are some special situations, and including the recent advance, we'll be covering in next 2.5 hours. So I welcome Dr. Varisha to have the first session, and then I will be taking up the discussion part.
Thank you, ma'am. We move forward with our first case. Gravida 2, previous one abortion, Mrs. X, 32 years, married for 3 years, presented to our antenatal clinic at 12 weeks of gestation. In the first pregnancy, she had a spontaneous conception, which was a missed abortion at 8 weeks, and a dilatation and evacuation was done. Her blood group was not known, and injection anti-D prophylaxis was not given. In the present pregnancy, it was a spontaneous conception with a normal ultrasound at 8 weeks of gestation. And when the practitioner found a blood group of A negative, she was referred to us. When she came to us, we got the following test done. Husband's blood group was A positive. Indirect Coombs test was negative. All the other investigations were normal. So a diagnosis of Gravida 2, previous one abortion, with 12 weeks of pregnancy with RH negative non-isoimmunized pregnancy was made. We got a repeat indirect Coombs test done at 28 weeks of gestation, which was negative. Hence, an antenatal prophylaxis of injection anti-D 300 micrograms intramuscular was given in the deltoid region. She had a spontaneous pre-labor rupture of membrane at 37 weeks and 5 days, and an emergency cesarean section was done in view of fetal distress. Delayed cord clamping was done, and she delivered a male healthy 2.7 kg baby. The cord blood investigation showed a blood group of A positive, a direct Coombs test was negative, and she received a postnatal prophylaxis of 300 micrograms after this result. The baby, as expected, did not require any phototherapy and was discharged on day 3 of life. So the learning points from this case is that blood group is the single most important antenatal investigation. The monitoring of non-isoimmunized pregnancy with indirect Coombs test, prophylaxis as antenatal prophylaxis at 28 weeks, followed by a postnatal prophylaxis when we receive the baby's blood group. We'll discuss the precautions during delivery and types of injection anti-D, that is polyclonal versus monoclonal, subsequently. So Rh negative population in India is 4.5 to 7%. The prevalence of Rh negative pregnancies is around 5%. Worldwide, we see 3.7 lakh cases of Rh hemolytic disease per year, and it is surprising that India contributes to 15% of them. The overall incidence of Rh isoimmunization is seen to be 1.3% in northern India. So coming to the management of a non-isoimmunized pregnancy, whenever a D negative woman presents to us, we first get an indirect Coombs test done with, if we can, a husband's RHD status. If the ICT is negative on the first visit, ideally we should repeat it every 4 weeks, or we can get it done at 28 weeks. If the ICT still remains negative, injection anti-D prophylaxis is given at 28 weeks. We follow the pregnancy as any other obstetric patient, and delivery has to be done not beyond 40 weeks. Postnatal prophylaxis has to be given depending upon the baby's blood group. Coming to the precautions that we have to take during a delivery, we have to make sure that there is no stripping of membranes. We do not apply fundal pushing during the first or second stage of labor. We do not have to massage the uterus or grasp or squeeze it in the third stage of labor. Manual removal of placenta to be avoided, and placenta has to be delivered spontaneously using control cord traction without squeezing the uterus. The cord should be kept as long as possible for exchange transfusion. If there is PPH, oxytocin is the first line and should be used instead of ergometrin or methergin. We have to protect the vaginal and perineal wounds and laceration from exposure to from fetal blood, and cord blood investigations to be sent, including blood group and direct Coombs test. And if we suspect isoimmunization, we can get bilirubin, hematocrit, hemoglobin, and reticulocyte count done. So in this case, we'll be discussing how prevention is better than cure, and I request ma'am to carry on with the session.
So what we see is in Rh positive patient or a blood group when Rh positive, the RBC has got these antigens which are on the surface. And in case of Rh negative blood group, RBC doesn't have all those antigens present. And hence these antigens, they initiate a antigen antibody reaction. So if Rh negative woman gets exposed to Rh positive cells by any means, that means with these antigens, then definitely these antigens will have a reaction, and this Rh negative person, why this is coming here? Okay. So this Rh negative woman develops some antibody, and these are the circulating antibody that are present in this, in the circulation of such a woman. So Rh negative women, individuals exposed to Rh positive cells, that is by delivery or pregnancy, then they produce antibody, and this antibody remains lifelong, and you detect them by doing a indirect Coombs test. When we are doing indirect Coombs test, we are doing nothing but identification of these antibodies in the circulation, and these antibodies are, whether when ICT says positive means they are antibodies are there, When ICT says negative, then these antibodies are not there in that circulation. So the risk of isoimmunization, as we saw in this case, she had a first pregnancy which had a dilatation and curettage, but she did not develop any antibody. Is it so? If a pregnancy is missed, should it always that all these pregnancy will have antibodies, development of antibody? Because the feto-maternal hemorrhage is so small, it doesn't create an antibody reaction, and hence all women, they do not produce an antibody. It is only 15% of them after exposure will have an antibody. Then coming on to further dissecting that 15%, if the husband and wife are ABO compatible, then the risk of isoimmunization or developing antibody is more, that is 16%. And if they are incompatible, then it is only 2%. So if you see an incompatible husband and wife, then you should be happy about it. And if you give postnatal prophylaxis only, then it is 1 to 2% that remains isoimmunized. And if you use both antenatal and postnatal prophylaxis, as was done in this patient, so you reduce this 1 to 2% risk to 0.2% risk. So the best practices, both antenatal and postnatal prophylaxis. So what did we learn from this case is that we monitor the patient the first visit, 8 weeks, 10 weeks, 12 weeks, whatever the weeks, 30 weeks, 34 weeks. First is we do a indirect Coombs test. If it is negative, then we think of giving antenatal prophylaxis. When it is to be done? It is to be done at 28 weeks. Then we continue the pregnancy. This pregnancy should not be continued beyond 40 weeks. We deliver such a woman at 40 weeks, and at 40 weeks we do those steps, or we do not do those steps that was said previously, and we send the cord blood for a blood group and a DCT. Blood group is positive, then we give an anti-D. So this is how we monitor a pregnant patient. Coming on to this patient presenting at 8 weeks, yes, we do monitor 4 weekly. Ideally, one should do 4 weekly ICT, day-to-day practice, and for various reasons, we may not be able to do it, but we must do it 28 weeks. So ICT 4 weekly till 28 weeks negative, we give an antenatal prophylaxis, do the deliver at 40 weeks, do the cord blood group, RH positive, give postnatal prophylaxis. So what are the other indication apart from this delivery? Other indication of giving anti-D prophylaxis is if you have a complete or incomplete spontaneous abortion, what we miss out. Then therapeutic termination of pregnancy with surgical and or medical technique. Many a times we see that the patient takes over-the-counter medical pill or ends in having a ICT positive. Then antenatal hemorrhage. If you have history of bleeding PB, we will be discussing subsequently. History of fetal intrauterine death in a RH negative woman and you suspect abruptio. Then ectopic pregnancy, embryo fetal reduction, or you do any invasive testing like amniocentesis, chodocentesis, CVS, abdominal trauma, external cephalic version rarely being done, or any treatment to the fetus that we sometimes do, we give it this anti-D. So what is international recommendation? Single dose, double dose. Those like my era, we get confused, 2 doses, single dose. The consensus now is that antenatally it should be given single dose. All countries, they agree, except Australia. Australia gives 2 doses, 28 weeks, 34 weeks. And rest all countries, they say 28 to 30 weeks. You give a single dose of injection anti-D. Now, SCOG says the same thing, but when it is to be given as soon as possible, that has to be within 72 hours. If not given within 72 hours, then up to 10 days after the event. Then according to some author, prophylaxis can still be attempted, even it is delayed up to 28 weeks. So you must give within 72 hours. If for some reason it was not given and patient reports, or you remember that, oh, I forgot that. So then you recall the patient and give it, even if it is up to 28 days still. Where it should be given? It should be given in the deltoid muscle, not in the gluteal region. Please instruct your staff nurse to give it in the deltoid region, not in gluteal muscle, because it causes less absorption. Whereas in deltoid, it is absorbed well. So coming on to where prophylaxis not to be given. So there are situations, suppose your ICT is positive, will you give a dose of anti-D? She has this circulating antibody and then injection anti-D, what it will work. So injection anti-D not to be given if your ICT is positive. Then if cord blood is RH negative, that means fetus is RH negative, or RH positive but DCT is again positive. That means fetus has got, your circulating antibody has crossed the placenta and has gone to the fetus. So RH positive, in those cases, you will not give an injection of anti-D. We face a lot of this query from the patients that this injection is to be given even if the patient has received intrauterine transfusion. That means such huge amount of antibody, they keep on saying that injection nahi laga, please laga dijiye. Injection will not be effective in those cases. Coming on to the question of monoclonal versus polyclonal, that is our day-to-day dilemma. And what is a polyclonal is, it is prepared from pooled plasma of hyperimmunized male donors. So those O negative donors, males, they are exposed to positive cells and then they develop antibody. There are pooled sera and then antibody is prepared. That is called as polyclonal. And monoclonal, these are produced by mouse human heterohybridoma cell line, and subsequently there is one is polyclonal, one is monoclonal. The next one which we are not discussing is the recombinant. So in the market, the recombinant is available. Why it is? So I have got 2-3 slides for it so that we understand why this recombinant DNA or anti-D, the injection name is anti-D, is available. Polyclonal covers all epitopes. So all these antigen, this RHD antigen has got different epitopes. Now polyclonal covers all these epitopes, whereas monoclonal covers less than 30 epitopes or less epitopes. So, and monoclonal doesn't have a proven technology. I will come to this discussion. Then there are different trials. The polyclonal is being used since 1968. It has completed phase 4 clinical trials. But as I said, it depends on plasma donors, and that donors are very, very less following COVID. So following COVID, the supply of polyclonal has decreased drastically. And this is approved by US FDA, polyclonal. Monoclonal was in phase 3 trial. And I'm coming on to the trial that was done in India. So different body naturally, SCOG, NICE, NHMRC, RC, Australian, New Zealand Obs-Gynae Society, then SOGC and RCOG, all of them, they recommend polyclonal. So where do we stand is in India? We do not have supply of that, just a minute. Yeah, but where is monoclonal stand? Monoclonal and recombinant has almost the same principle of generation. So the literature that I found in monoclonal was in Lancet 1990. They started saying that monoclonal antibody may prove suitable for immunoprophylaxis of RHD in 1990. Then subsequently in 2007, various study, and after following phase 1 clinical trial, they recommended that none of the products developed are effective in phase 1 clinical trial. So in last 20 years, 19 monoclonal or recombinant antibodies are produced. and the side effects are heterogeneous. Now next come is in 2024 March, there is an article in Lancet saying that monoclonal RHD prophylaxis, this is high time to evaluate the efficacy. So let's sit down, think over, we have got only monoclonal. If we have only one option of wearing, say for example, one sari, then let's wear that sari and be happy about it, and then think that how it presents you. So similarly, we have got monoclonal with us. We do not have supply of polyclonal. And this article of Lancet says that it is time to evaluate the efficacy. What is the efficacy? The supply of the polyclonal is insufficient to meet the needs of all women at risk worldwide, and there is a drastic decrease of supply. Extensive and rigorous trials necessary to prove that monoclonal is effective. So hence, a post-marketing phase 4 trial needs to be done. And there are two trials done in India, one with 110 women and another was 105 women. It makes 215 women, but 186 followed up, the rest were lost to follow up. And in these two trials, these 186 women at 90 days and 180 days, their ICT remained negative, and that thereby they are saying that there is these monoclonal are effective and can be used. But this Lancet article itself says that you need to look into the efficacy with a larger study. It is only 186. All of us are using monoclonal. We are forced to use monoclonal. So all of us should think, how do we measure this efficacy? How can we measure the efficacy? If injection of monoclonal anti-D is given day 1, so then it is expected that these circulating antibody are there in the circulation in say 48 hours. So if you do a ICT, it should be positive. At 90 days, if ICT remain negative, the woman got exposed to Rh positive cells, you have given an injection and then ICT remain negative, probably this injection is working. So to this audience, the countable number, but then still I will, they are from AIMS Raebareli, from high practitioners, volume of practitioners. So what my suggestion is that all of us, let's start doing ICT after say 48 hours, and then subsequently at 90 days or 3 months, and then see how many of them, and then start reporting or collecting our own data that a Rh negative woman delivers a Rh positive full term or abortion or whatever is given anti-D, and 48 hours is positive, 90 days is negative. So that means monoclonal is active. If this report of 186 turns into 18,600, then we can prove that from India, this is the data, and it can be given in worldwide. What they did, there was a short supply of anti-D. If you have short supply of anti-D in a country like US, then they shut down. The FICO recommendation came in 2021 because of this short supply of polyclonal anti-D. So they prioritize the women, high priority, middle priority, and low priority. So if you have short supply, you give to the high priority people, and you think of giving middle priority, but low priority you may or may not give. And may or may not give category is amniocentesis, CVS, external cephalic version. These are done very rarely by everyone. So these are those antenatal invasive procedure that you may avoid giving it if there is a short supply. The high priority is Rh negative women delivering Rh positive. You must give, whatever the cost is. Then middle priority is antenatal prophylaxis. In the initial slides, I said in postnatal prophylaxis, it is 1 to 2%. In antenatal prophylaxis, if you give, then this will reduce to 0.2%. So you may end up giving postnatal prophylaxis and may avoid giving an antenatal prophylaxis. That's the reason they kept it as middle priority. Surgical abortion or ectopic pregnancy of all gestation, after spontaneous or medical abortion, miscarriage after 10 weeks, bleeding, abdominal trauma, or fetal death. These they put it into middle priority. For us, all priority are equal. We have got supply of anti-D. We must give to all women. Please do not carry this to home and start practicing. It is for us, polyclonal is not available. We have to give monoclonal or recombinant DNA and anti-D, and then we have to give this. For us, it is time to sit down, think, and start doing this test and start keeping our data so that we can vouch for it. So to summarize this case, ICT at first antenatal visit, everyone agrees. 8 weeks, 10 weeks, 12 weeks, whatever it is. Okay? The senior resident and the junior resident. If you start clicking picture, then you will forget. You start clicking picture in your brain. See, ICT is first, only one visit, antenatal visit. That's done. It's so simple. ICT negative, do a 28 weeks, and then when you are delivering such a woman in the labor room, please collect cord blood. Otherwise, your neonatology friend will prick the baby. You want this baby to be pricked? No. You have the cord to collect the blood. So you please collect the blood, and which vial you will collect, we will come on to it. And delivery not beyond 40 weeks. Then precautions we have said, and test for efficacy. This is for all of us to think over and then start practicing this, which is not written. So, questions from audience. What sample is sent for ICT? Yes. Blood in EDTA, blood in plain vial, blood in citrated vial, cord blood. So I invite my next Dr. Saima to present the next case.
So moving forward with our second case, patient was 30 years with gravida 3, para 1, live 1, abortion 1. She was referred to us in view of RH isoimmunization. Her first pregnancy was supervised, uncomplicated. Her blood group was O negative. Antenatal ICT was negative. She had full-term cesarean section in view of breech presentation. It was a male baby, 3.2 kgs, alive and healthy. She received routine antenatal and postnatal anti-D. Her second pregnancy was spontaneous conception. She had took over-the-counter MTP pill at 7 weeks. In this pregnancy, she did not receive anti-D. In her current pregnancy, this was a spontaneous conception. Her first trimester was uneventful. Aneuploidy screening was not done for her. In second trimester, her T5 scan was normal. At 18 weeks, patient was referred to us in view of RH isoimmunization. Her ICT repeated at our department. It was 1:4. Titer was 1:4. Her titer was repeated every 2 weekly thereafter, and it remained below the critical titer. In this pregnancy, she had underwent elective cesarean section at 38 weeks in view of previous cesarean with breech presentation. She delivered a male baby of 2.7 kg. Apgar score was 8 and 9 at 1 and 5 minutes. Cord blood of baby was, blood group was A positive. DCT was 3 positive. Cord bilirubin was 3 milligram per deciliter. Hematocrit was 39%. And reticulocyte count was 5.4%. Baby was diagnosed with neonatal hyperbilirubinemia and received intensive phototherapy for 48 hours. And baby discharged with mother on day 7 of life. So, learning point from this case is MTP can cause isoimmunization if prophylaxis is not given. If no prophylaxis, prophylaxis should not be given if ICT comes positive. In cases of positive ICT, monitoring should be done every 2 weekly, and patient should not deliver beyond 38 weeks. and baby should be monitored for jaundice. So whenever a patient comes to us with RH positive and ICT positive report, then mother should monitor every 2 weekly for ICT. And if it remain below critical titer, pregnancy should not be continued beyond 38 weeks. So ICT may remain positive up to 2 years post anti-D. So careful interpretation of ICT titer to differentiate passive versus active sensitization. Low titer, that is less than below 1:4, indicates passive immunization, while rising titer indicates active immunization. So what are the possible causes of non-responder? That patient remain ICT negative after anti-D is immunological factor, insufficient dose of anti-D, delayed administration of anti-D immunoglobulin, and pre-existing sensitization, or there is defective storage or handling issues. Now I would like to call upon HOD ma'am for further discussion.
So this case we saw that, So this case we saw that this was ICT positive. So from negative ICT, we moved on to the next case, that is ICT positive, but this positive is less than critical titer. We saw that patient had an over-the-counter MTP pill and had an MTP. So over-the-counter MTP pill is really has caused a lot of isoimmunization to my experience. So MTP can cause isoimmunization. And if ICT is positive, already positive, then we should not give an injection of anti-D. So this patient had an ICT positive, less than, more than, forget about it, already ICT positive, no antenatal prophylaxis. And your monitoring should shift from 4 weeks to 2 weekly. So now what do you monitor? She is already ICT positive. You monitor what is the quantity of antibody, or that means antibody titer. So how do we do an antibody titer? Is little 2 slides on ICT, so that at least we as an obstetrician should understand what is an ICT. See, here is a blood sample and we know that there is serum. Say for example, this patient has got YY indicates the antibody present in this, and they are circulating. This serum, in this sample, what is being done is known O positive is added. So known O positive has got these antigens, and this antibody, circulating antibody, gets attached onto it. So RBC has got antigen which are positive, then antibody which are circulating is attached, and now they are circulating. They will, in a test, they will not agglutinate. For agglutination, or for to identify this antibody, presence of this, a cum sera is added onto it, and this is the cum sera which will bind onto these against these antibodies, and hence this will bind to each other and makes clumps, and these clumps are identified. So in an indirect Coombs test, what we are identifying is whether this sera has got these antibodies or they are not there. If agglutination is not there, then we know that it is negative, and agglutination is there, then the report will come as positive. So now this is this is okay. By mistake, this has become indirect. This is a direct Coombs test. So this is not a indirect Coombs test. This is a direct Coombs test. I will come on to it. Just a minute. So what is a cum sera? Cum sera is actually this yellow thing that we have taken out is the antibody against this antibody. So antibody. So double anti. So how do they next? This is the titer. How do they do? First, they take that sera, dilute. First is the sera as such is positive. Now they dilute it, put equal amount. So 1:2 positive. Then 1:4. Again dilute. Then positive. Then 1:8. Again dilute. So 1:8 is positive. Then 1:16 is, say for example, negative. So the report will come as 1:8 positive. That means 1:16 is negative. 8 times dilution of the sera, still the antibody can be identified. So it indirectly indicates we can't quantify this antibody. So what is being done is this is diluted how many times, and so you get a report always multiples of that 16, 32, 64 and then 128 like that. You will never get a report of 1:110. A lab which gives a report of 1 positive in 1:110 is a wrong report, and the lab is practically not doing it and not knowing also. So this is 1:8 positive. This is how we do a antibody titer. So antibody titer indirectly indicates what is the amount of antibody it has. So antibody titer is 1:8 actually. So this is and what is a direct Coombs test? We do it on cord blood. In that, in the cord blood, say in the cord blood, this is baby's RBC, baby's RH positive. Okay. So baby's RH positive means these blue dots are antigens are there on the RBC surface. And say, for example, baby is already exposed to the antibody. So baby is in that. We are trying to test whether this is there or not. Now we add Coombs sera. So once Coombs sera is added, this will clump together. If the baby's RBC are coated, if it is not coated with antibody, they will not have any agglutination. So in a direct test, we are directly putting it and then getting the test done. And it is done in cord blood of the baby. Never send a direct Coombs test on mother's sample, and that is done in some other condition. So please let us not discuss. So that is direct test, and in indirect test, putting a O positive blood is an extra step, and that is why it is indirectly estimating, and hence it is called indirect test. Okay, so I knowingly I spent this. So potential sensitizing event, we saw that high priority is delivery, and in during delivery sensitization may be as high as 45%. Intrauterine fetal death 13, ectopic pregnancy, threatened abortion, therapeutic termination of pregnancy. Then comes antenatal procedures, which are 2 to 6%. Spontaneous abortion, asymptomatic feto-maternal hemorrhage, which could be 2%, and evacuation and external cephalic version. So these are potential sensitizing event. And as madam said that if a patient continues to bleed, then what should we do? So volume of feto-maternal hemorrhage leading to RHD alloimmunization can be as small as 0.1 ml, or it may be as large as 30 ml. So 0.1 ml of fetal blood can sensitize a woman, and hence can produce antibody. Again, these are slides that I love them. I have made them, and I feel that this explains very simply. So this is RH negative woman who has got these YY things or antibodies circulating. So if you do AICT, then ICT will be positive, negative, positive. Yes, I'm always looking at you. So GR is the one who will have lot of pores. The junior resident is a residency system has got multiple pores in the brain. So everything goes in. So as you grow old, all these pores get occupied. So all your pores are this thing. So you have to learn it multiple times. GRC, once reading, done. So these are ICT positive. Now this ICT positive woman has become pregnant. My drawing is, sorry for that. This uterus has got multiple fibroid, looks like. So now the baby's blood group is RH positive. Okay. What will happen? This antibody will cross the placenta and then comes on to this RH positive fetus, and then this will coat this RH positive fetal blood cell. So this is an isoimmunized pregnancy, and you quantify this antibody, and accordingly you think that what is the risk to the baby, which we will be coming on our next case. So, and it causes hemolysis of the fetal RBCs, and this hemolysis leads to drop of hemoglobin, and drop of hemoglobin means that you anemia, fetal anemia. Great, Dr. Geeta. So, any questions from audience? What's a high titer? MCA-PSB is more than 1.5 mmol. When you see high drops, more than 1:16, different for different lab. What is a critical titer? We will be explaining in our next this thing. Is that it is not the MCA-PSB. MCA-PSB is for fetal anemia. Anemia may be 2 gram%, 3 gram%, anything less than 10, there will be MCA-PSB raised. When high drops is seen, it is the last stage. More than 1:16 for my lab, it may be 1:8. For your lab, it may be 1:16. And for another lab, it may be 1:32. So it is never constant. So hence, do not learn that ICT more than 1:16 is high. It is different for different lab. You please talk to the lab people or fix a lab from where you get your ICT done, and then try to follow up these babies. That is what I have done in my lab. And we have determined that our ICT titer of 1:8 is the critical titer. For us, it is 1:8. It may not hold true for everyone. So it is different for different lab. Okay, great. So I invite the next Dr. Ruchi to carry on. We have finished with RH negative, non-isoimmunized, then RH negative isoimmunized but less than critical. Now we move on to more than critical. There is no randomized trial of monoclonal versus polyclonal in any of the literature, and it was not done. When it was started in 1968, it was started with polyclonal, and there was phase 1, phase 2, phase 3, phase 4 clinical trial on polyclonal. Because there is no double-blind trial, so we cannot say that it is equally effective. Then there was a phase when only monoclonal was tried, and they saw that could be used, and it can be, because there is a short supply, so definitely we should look for the other option. So then monoclonal was thought about. Then there was some trial and said that it is effective, but not maybe equally effective. There is no sentence called equally effective. So it may be effective. So now that we have got only monoclonal, we should not think also about polyclonal, what people in US or Australia, they think about. Okay. So if we have only monoclonal, so let's do it. Rather than giving nothing, use something, and that is monoclonal. And the recent article in Lancet says that exactly it says this, that this is time to evaluate the efficacy of monoclonal. So or the recombinant anti-D. So this is time. How do we do it? We should put our brain, if this is half-life, then this within that half-life there should be some this thing. We should negate those non-responder for which there is no test. It's only follow-up, and then follow these women extensively, and then start seeing that whether they are producing antibody or not. We can have a multicentric collaboration. Those who are present over here, please think over it, and then please join with me so that we can have a this is nothing. We can see, this is what is available. I'm not ethically wrong in giving it. If something else is available, then I may be using it. I have got polyclonal. So efficacy will be the greatest or the largest use of this monoclonal, and we can look into it. Sit down and then, yes. So we move on to the next case.
Thank you, ma'am. Our next patient, Mrs. X, 39-year-old, fourth gravida with previous one living issue and 2 abortions. She's married for 12 years. Her first pregnancy was spontaneous conception. It was a supervised pregnancy. She was aware of her blood group, but ICT was not done. and no antenatal prophylaxis was taken. She delivered a female baby of 2.7 kg at 39 plus weeks. Cord blood group was positive, so mother received NTD within 72 hours of life over deltoid. That baby is alive and healthy. In her second pregnancy, it was a spontaneous abortion at 6 weeks. There was no history of instrumentation. She received NTD within 24 hours of abortion over deltoid. Her third pregnancy was in 2023. It was a spontaneous conception. She had threatened abortion at 8 weeks of gestation, but at that time, she did not receive NTD. On her double marker, there was increased risk of trisomy 21. It was done without doing nuchal translucency. At that time, ICT was not done, and pregnancy was terminated on the basis of double marker only because it was suggestive of high risk for trisomy 21. And at that time, she received NTD within 24 hours of termination over deltoid. In her next pregnancy, it was in 2024. It was a spontaneous conception, and she referred to our department at 14 weeks of gestation with ICT positive. We investigated her. Her blood group was B negative. Her husband blood group was O positive, and ICT was done at 16 weeks. It came out to be positive, and on antibody screening, NTD and NTC antibody were identified with titer of 1:4 and 1:1 respectively. On other investigations, her HbA2 and HbF was 5.3 and 3.7 respectively, and her husband HbA2 and HbF was 3 and 0.3. So, what is the diagnosis? Audience, please. As patient's HbA2 was 5.2 and HbF was 3.7, what it could be?
Again, you can get a Kit Kat. Yeah. Thalassemia? Minor, great. So, 2 Kit Kat. Husband? Normal. Next.
So wife is beta thal trait and husband is normal. So next question. What is the risk to the fetus of getting thalassemia?
Never be major, but child can be minor. Should I test for minor? Should I do a invasive? No. Great. Again, Kit Kat. So this, see, you get Kit Kat till this box gets exhausted. So but what is the risk? Yeah. Risk of minor is 25%. Recalculated. Risk of minor is 25%. 50%. Yeah. But we are not bothered about minor, na? So let's not bother about it. Let's not go into the discussion of that. But there is risk of ICT is 1:4. So the risk of isoimmunization is there. So move on.
So we monitor the patient with serial antibody titer. Her antibody titers were 1:4 at 18 weeks for NTD, 1:4 at 23 weeks for NTD, and at 28 weeks of gestation, it came out to be 1:8, which is critical titer for our laboratory. And when NTC remains 1:1 throughout the gestation, and as the titer reaches 1:8, we started monitoring of fetus with MCPSV. So with MCPSV, the fetus was monitored 2 weekly, and the MCPSV remains normal throughout the gestation. So as it was an isoimmunized pregnancy, induction of labor was done at 36 weeks of gestation, and she delivered vaginally. Baby was male, 2.9 kg with good Apgar, and we did delayed cord clamping. And on the birth of the baby, a cord blood investigation as follows. It was a B positive blood group and DCT was +2. Hematocrit was 41% and bilirubin was 3.94. So baby immediately kept on phototherapy, but bilirubin was on increasing trend. So double volume exchange transfusion of neonate was done on day 1 of life itself, and currently baby is day 10 and still on phototherapy. So what is the learning point? If a blood group of women is negative, so we should not forget to look for other routine antenatal investigations, as this patient was beta thalassemia trait. And second point, her last pregnancy was terminated on the basis of screening test only, as it was high risk for trisomy 21 in double marker. It was done even without confirmation, without any diagnostic testing. That should never be done. So, what is critical titer? Critical titer is titer. After that, hemolysis of newborn to be looked for, and for our laboratory, it is 1:8. So, as in our patient, patient has taken all the prophylaxis in all her pregnancy, but despite of prophylaxis, she was isoimmunized. So what could be the causes of isoimmunization despite taking adequate prophylaxis? It could be unrecognized fetal-maternal hemorrhage, especially in first and second trimester, as the patient had history of threatened abortion at 8 weeks of gestation. So it could be cause of isoimmunization, or it could be of inadequate dosing because of non-availability of KB test. It could be of missed prophylaxis, inadequate cold chain maintenance, or improper technique of administration, or there is absence of prophylaxis for other RBC antigens like NTC, what we had seen in last case, and sometimes omission of minor typing for blood transfusion in women of childbearing age could also cause isoimmunization. So, to summarize, if RS negative women presents to us, we do ICT. If ICT is positive and it is less than critical titer, then we repeat it 2 weekly. If it is remains less than critical titer, then patient to be delivered at 38 weeks of gestation. But if it crosses critical titer or if reaches critical titer, then we monitor with MCA-PSV. If MCA-PSV is within normal limit throughout the gestation, then we deliver the patient at 36 weeks.
So what is the definition of critical titer? This patient is for monitoring, and the monitoring is by MCA-PSV. So monitoring. So how do you do MCA-PSV? So next, I am telling about MCA-PSV. How do we properly do it? And what is late cord clamping? Should we do late or early? Early? GR1 will say early. Senior resident will say late. GR1 will think all those antibody in the maternal circulation and will think that if I delay the cord clamping, then all these antibody will cross through this cord blood. Very right. The thinking process is exactly that. The SR has read her GRC. She's a good SR reading after joining the SR also. And she will say that, no, I have read that the current recommendation is delayed cord clamping. I'm coming on to it. Yes. Yes. I, as a JR, was thinking, why not do jaldi so that these antibodies will not cross. Okay. So what is proper measurement of MCA-PSV? It should be measured properly, and I have got a video for it. So let me spend 3 minutes in it. So what is done is you focus this BPD plane, then go zoom your image. The image is zoomed. Now this you go little below towards the base of the skull, and now switch on your color Doppler. You will identify the circle of Willis. So this is circle of Willis. You identify. Now this is the middle cerebral artery. So you take your power Doppler and then put it, and you correct the angle. See, angle is corrected. Yeah. So, yeah, decrease. So now yeah. Okay, so the MCA will come as, you measure how many times? 3 times, yes. So you measure 3 times and take the maximum value. So here the MCA PSV is 92. So sometimes it is 82, sometimes it is 92. So how do you measure is axial section, level of sphenoid bone. Nobody looks into sphenoid, but you can identify the circle of Willis close to the transducer, not the artery which is away from the transducer. So the one which is coming up or closer to the transducer, or it is the towards the transducer. Then zoom your image, at least 50% of the image should occupy your this thing, the screen. Sample close to its origin from the internal carotid artery. Do not go away from something like that. You need to be, yeah. Oh, yeah. So your power gate should be nearer to this origin of this middle cerebral artery. So do not put your image here, the gate here. You need to put it at the origin of this. This, in fact, this we recorded on 29th of January, 2 days back. We recorded for this lecture only. So sample close to the origin of internal carotid artery, and the angle between the direction of flow and your ultrasound beam should be the parallel, and hence you rotate and correct the angle. Then the highest level of the 3 value should be taken. So here the middle cerebral artery peak systolic velocity is 90 at a gestational age of 32. Is it normal? It is abnormal. At 32 gestational age, it is. Now, after this lecture, this JR3 will take a lecture for rest of this thing, obstetrician in your hospital. So how do you say whether this is normal or not? You go to perinatology.com and put the value. Everybody will not have a internet connection. Everybody carries a mobile but may not be able to use. But instantly, how do you say? When you are sitting in a hall like this is this period of gestation in weeks multiplied by 2. She is 32 weeks multiplied by 2 becomes 64. 64 is the highest value. Anything above it is high MCA PSV. So let me go on to 32. 32 weeks, 1.5 MOM, 66. So this table one can refers to. This is the table that I have made from the chart only. So there are values, and the values almost corresponds to the double of the gestational age in weeks. So if she is 20 weeks, 20 multiplied by 2 becomes 40. If MCA PSV is more than 40, then MCA PSV is more than 1.5 MOM, which indicates moderate to severe fetal anemia, and the patient is for intrauterine transfusion. So this is how MCA PSV is taken and MCA PSV is interpreted. In many a times, even I do not go into this chart. I just look into the MCA PSV, gestational age, multiply 2, and then say that, oh, it is high, the patient needs to have a intrauterine transfusion. Okay. So the allo immunization is increasing. This is, see, this September 2024 news, and this is in US, it is increasing, probably because short supply of polyclonal. And they say that all these 3 antibodies, they are major antibodies, that is D, then C, and then Kelly. All of them are increasing. So they are from 2010 as compared to 2010 and 2021, these are increasing, and hence the seeing more of patients of allo immunization. Like there were days when they were doing 1 or 2 transfusion in a year. So now this is increasing. So now after MCA PSV, we come on to early versus late cord clamping. Delayed cord clamping and risk versus benefit. What are benefit if we do a delayed cord clamping? It increases neonatal blood volume and iron store, that all of us know, that is why we do it. Improves packed cell volume at birth. No significant increase in exchange transfusion needed. When we did, there were double-blind trial. When they did delayed cord clamping, the exchange transfusion were not increased. And hence, delayed cord clamping can be practiced because the benefits are more. SCOG supports delayed cord clamping for iron stores improvement in the newborn. What are the risk? There is no risk. It's not coming. Yeah, risk. So risk of transfer of antibodies and increased risk of neonatal jaundice, higher need for phototherapy, increased risk of RH alloimmunization remains unproven. And hence, you should be, yeah, if a patient is RH negative, non-isoimmunized, there is no antibody, then definitely that's a normal pregnancy. You can do a cord clamping, delayed cord clamping. Now is a positive with a less than critical titer, so less amount of antibody. Whatever will be transferred probably will not cause that this thing. But a patient who is more than critical titer may have fetal anemia, which is say 11, which is not detected by MCA-PSB, not requiring transfusion, still have little amount of this thing. Still, if we do a delayed cord clamping, that will improve the hemoglobin of the baby. So that improve iron store and improve PCB, packed cell volume, has got more benefit than the risk, and hence a delayed cord clamping should be practiced across in RH isoimmunized, non-isoimmunized, all of them. So if you will not ask question, I will go on asking questions. So detection of fetal hydrops at 22 weeks. What is the best management? Should refer. So our next case is RH isoimmunized more than critical, MCA-PSV, this thing with hydrops, and I invite Dr. Samreen to do this.
Thank you, ma'am. So for our next case, we have Mrs. A. She is 21 years old, Gravida 3, Para 1011, with previous cesarean section. She is RH negative pregnancy and she was referred to MRH at 27 weeks with hydrops fetalis. Her obstetric history is like she was married for 3 years. Her first pregnancy was 2 years back. It was a missed abortion at 8 weeks, for which dilatation and evacuation was done. And she was not knowing her blood group and she did not receive anti-D. Second pregnancy was 1.5 years back. She was supervised at private hospital Patna. She received anti-D at 7th month. ICT was not known. There was history of antepartum hemorrhage at 9th month, for which she was diagnosed with placenta previa. So emergency cesarean section was done in view of symptomatic placenta previa. She delivered a live-born girl of 2.5 kg. She did not receive anti-D in postpartum period. Baby blood group was B positive. There was history of neonatal jaundice on day 3 of life, for which baby received phototherapy for 4 days. And now baby is alive and healthy with normal milestones. This is her third pregnancy, and she was supervised at private hospital Patna. Her NT&B scan was normal and IPT was done, which was low risk. TFOB was suggestive of no gross malformation, but ICT was not done. USG at 27 weeks was suggestive of fetal hydrops with MCA PSV of 2 moms. After referral, her investigations were done. Blood group was B negative and husband's blood group was B positive. So attention. If we have, is it good to have same blood group in couple? So we did her ICT, it was positive, and RH antibody titer was 1:512. This was her ultrasound, which we did at MRH. This is fetal heart. We can see there is cardiomegaly with pericardial effusion in this scan. We can see increased skin thickness or skin edema is there. In this image, we can see there is fetal ascites. So clearly it is the case of fetal hydrops. And as expected, we did MCA PSV and it came out to be 77 at 27 weeks. So it is increased. So hydrops is the abnormal accumulation of fluid in 2 or more fetal compartments. It is a fetal emergency, and if we are seeing a hydrops on ultrasound, it indicates that hematocrit is usually less than 15%, and mortality is 100% without intervention. So we counseled this patient about the need, about the procedure, raised some complication associated with intrauterine transfusion. We admitted her and we prepared for IUT. Antibiotics were given and tocolytic was given, and steroid was covered for fetal lung maturity, and informed consent was taken for intrauterine blood transfusion. Blood preparation was done for intrauterine transfusion. So she received first intrauterine transfusion at 28 weeks. Pre-transfusion hematocrit was 8%. That means hemoglobin was 2.5 gram per deciliter. Post-transfusion hematocrit was 28%. Cord blood group was done. It was B positive. Second transfusion was done after 2 days, and hydrops was resolved after 2 transfusions. Subsequent transfusions were done based on her expected hematocrit, and total number of transfusions were 4. She had elective cesarean section at 35 weeks 1 day in view of RH isomenized pregnancy with previous cesarean section with short interconception period. And she delivered a live-born boy of 2.5 kg with ABCAR of 7 and 8. Baby cried immediately after birth. Cord blood hematocrit was 42%. Total bilirubin was 2.8 milligram per deciliter. A baby received 1 exchange transfusion followed by phototherapy, and baby is now having normal milestones. In this patient, where we went wrong, as we saw that in her first pregnancy, dilatation and evacuation was done, but blood group was not known, so she did not receive anti-D. In second pregnancy, blood group was not known. Blood group was known, but RHD was negative, but ICT was not done, and she was given antenatal prophylaxis. After that, she had antepartum hemorrhage, but she did not receive anti-D. Antenatal prophylaxis was given, but she did not receive postpartum prophylaxis. In her third pregnancy, that was her present pregnancy, ICT was not done in her early pregnancy, which if we had said that ICT was negative, we could have been monitor her with the MCA PSV if titers were low. So what are the indications of intrauterine transfusion? It is RHD isoimmunization, minor blood group isoimmunization, like ICT is positive in RH positive women, parvovirus B19 infection, which can cause non-immune hydrops fetalis, placental chorioangioma, or twin arterial polycythemia, twin anemia polycythemia sequence. So non-immune hydrops fetalis, we have one case which was detected as non-immune hydrops fetalis because of parvovirus B19. This patient came with this diagnosis of fetal hydrops. Her MCA PSV was done, which was suggestive of fetal anemia. So it was clear that she was having fetal anemia, but her ICT was negative, so it was non-immune hydrops fetalis. Her amniocentesis was done, which was suggestive of parvovirus B19. So she received intrauterine transfusion for fetal anemia, and hydrops was resolved. And this is the baby after birth. So for parvovirus B19, how do we diagnose? We can diagnose after doing PCR on amniotic fluid, and sensitivity is 80 to 85%. We can do IgM on cord blood also, which is done after 20 weeks of gestation. Management is detection of fetal anemia and blood transfusion, and resolution of hydrops occurred by 3 to 6 weeks. Fetal survival rate is 82% with transfusion versus 55% without transfusion. I would like to request ma'am for further discussion.
So what we saw that yes, we can, these women all have no previous living child. Gravida, see the first patient, 10th gravida, hydrops, 7 IUT. Second patient, couple, 12th gravida, 6 IUT. Third patient, 12th gravida. It is not good to write 13th gravida. I have got a very strong feeling that 13th is not a very good number. So whether I will be successful in doing this patient or not. So I always used to write her as 12th gravida. She had previous 12 loss actually. So she is 12th gravida, let's say she lost 11 pregnancy. And in December 23, she delivered 6 IUT. See, all these patients were managed, supervised by my friends, means obstetrician. They are not those ones who had only home delivery. All of them went to hospital, had delivery, and all like then somewhere we have gone wrong. This patient, the case that she discussed from Patna, from a very well-to-do family, some manager somewhere, some lawyer, then were asking me why there is no emergency blood donation of O negative when you are writing Department of Emergency Medicine. So the mother-in-law was fighting that there is at 4 o'clock in the evening. They thought that blood donation will be done by 5 o'clock, blood transfusion can be done by 6 o'clock, which is practically not possible, and the baby will be saved. So they were sitting on our head. So by the time they were discharged, all throughout the management, they transferred themselves. And like the day one, we were not admitting her till the day of transfusion because they were such troubleshooting parents. Like we avoided them in admitting in our ward. But by the time they got the baby and got discharged, all idea about our department changed. At least they were cooperative. And they were threatening me that we will go back and sue the obstetrician of Patna, which is not good. So how do we avoid? We do a ICT, titer, more than critical, do MCA PSB, more than twice, refer. This is as simple as this. So if you learn this mistake, not able to diagnose and refer on time. If you refer with high drops, then I will tell the patient that 60% chance. So what's our experience? No, this is question from audience. Yeah. Fetal RBCs. Yes. So what she means that, say for example, it is incompatible. So if incompatible between mother and the fetus, then now this ABO incompatible cell comes into the maternal circulation. From fetus, few cells come into the maternal circulation which are ABO incompatible. Because of ABO incompatibility, this will be destroyed. The ABO incompatibility will destroy this cell and hence will not produce any antibody. Whereas ABO compatible will be not destroyed, and so that is why. Okay, then question for audience. Oh, wow, great. 8th gravida, 3 term, for preterm. If you are not aware about this formula, first is term, second letter is preterm, third is abortion, 0 abortion, fourth is live issue. So 1 live issue with previous fetal death at 28 weeks with high drops. How and when do you start monitoring this patient? This patient has come to you in her subsequent pregnancy, that is 8th pregnancy. You will do MCA PSB at 28 weeks. Serial antibody titer. She had previous history of high drops. She is 8 weeks. Serial antibody titer and then MCA PSB from 18 weeks, not at 28 weeks. No. Should I do a serial antibody titer in this patient? No. Why? She had previous pregnancy where she had high drops and fetal death. No. Yes, it was RH. So should I do an antibody titer? If I do it, that is for my own interest, maybe lab and all, and I will do a titer, and I expect that this titer will be more than the critical titer. So given a chance, I will not do a antibody titer, and definitely not a serial antibody titer. Okay, now what should I do? MCA PSB, great. So let me retire and go for a cup of coffee probably. No, okay, I have got intrauterine transfusion, then we will break for a cup of coffee. We will have a coffee break or should I continue? Continue? Interesting? Very good. So we do a, so when should I, how do I decide when do I start monitoring? 18 weeks, 28 weeks, previous तो 28 weeks में hydrops हो गया था. 18 weeks. 18 weeks. Previous hydrops at 36 weeks. कितने weeks? Patient is comes from Patna to SGPGI. Still 18 weeks. 18 weeks. पूरा ऐसे थप्पा हो गया. Okay. I will give the answer. No Kit Kat. Okay. So next few slides will be on fetal transfusion. You may not be doing because I do it. So I thought that I will show you what we do. It is freshly donated blood and that is within a week, preferably within less than 5 days. Most of our transfusion, almost 99.9% transfusion, very rarely we do more than 1 week. So we want a freshly donated O negative blood, cross-matched with mother's blood, then screen for everything, including CMV. Hematocrit is 75 to 85. So high hematocrit, that means the blood is prepared separately. Irradiated and licopoor. WBCs are removed by licopoor. They pass this blood through a filter, through a channel, so that all WBCs are filtered out and hence no reaction. You are giving to the fetus, you can't identify a reaction to the fetus. Fetus cannot complain fever ho raha hai, shivering ho rahi hai. So licopoor, then irradiated, so that we minimize the reaction to the baby. So this is how the bag is prepared. There is some the bag, and by the time the bag comes out, the price comes into 2,600 at PGI. They have calculated this lico filtration and everything, and it comes around 2,600, say roughly around 3,000 rupees. We take a consent, explain the procedure, risk of preterm labor, risk of fetal bradycardia and IUD or intrauterine fetal death. We give mother the uterine relaxant and antibiotics. Yes, internationally they do not recommend. We do give antibiotics to the baby, seeing that what is our current scenario. So it is an ultrasound guided procedure. Patient is not given any anesthesia. Spinal needle of 20 gauge is used. I do not use a 22 gauge. Baby is anesthetized if required with pancuranium. Then target umbilical vessel. The first sample is taken and sent to the lab for hematocrit, and the sample is called back, so that this hematocrit helps us in calculating what is the volume to be transfused and amount of blood to be transfused is calculated. The site is decided either intraperitoneal. Very rarely we do intraperitoneal, very rare. 99.99% is intravascular. Intravascular is umbilical cord at insertion, placental insertion, never at fetal insertion, maybe placental insertion. And we have moved on to intrahepatic umbilical vein use. Free loop sometimes if it is not accessible or the fetal position is such, we cannot do it. So this is a video showing how do we do. It is an ultrasound guided procedure. So we use this. Ultrasound is here. So this needle is going in. We give some amount of this thing, then we take so the needle goes in to this is anterior placenta and the cord insertion is over here. So the needle is put into this thing. The ultrasound is not exactly correlating this. The video I have made it. So the sample is collected, blood sample, and this blood sample is immediately transferred into the EDTA vial and a plain vial, and we send it for, first is for hematocrit, and then the same sample is used. Then we attach it with this attach it with the blood bag. With a three-way stopper, we collect it to the bag, the blood bag, and to the fetus. So we do not take out in syringes and keep it and then transfuse what other people do. We have a closed system. So we take from the bag into the syringe and push it into the fetus. So this is how it is being done. So we put it into the fetus. In between, we monitor the fetal heart rate. If the fetal heart rate continues to be regular, sometimes it may be irregular. Then if it is irregular, then we stop the transfusion for a while, monitor it, and then sometimes rarely we have to stop it because of tachycardia or bradycardia. See here in between we were doing this, and this is how blood looks like when it is flowing. So this is the blood is again refiltered and given, and at the end we put the stellate back and take a sample, and we wait for 1 minute. If everything is fine, then we take another sample, so that post transfusion hematocrit is determined immediately and after 1 minute. So if the placenta is posterior, then how do? We go into this thing, and we try to go into intrahepatic portion. But if it is not possible, then we go into the cord insertion at the posterior side. And this is how we do it. This is the cord, umbilical cord. The needle is coming in, and then now it will push. So I do this way into the, yes. So now it is piercing the umbilical vein, not the artery. So we try to avoid the artery, otherwise it causes vasospasm and then fetal bradycardia. So this is and the fetus is not anesthetized, it is moving its hand. And usually the fetus has got, and now the blood transfusion has been started. One can see this. So this is how it is being monitored, that the blood goes in. So this is a transfusion in the posterior placenta, and this is a transfusion into the intrahepatic portion. This is what we usually do these days. So this needle is coming, the fetal abdomen. This is the fetal liver, ascites, one can see. And this is the needle tip which is coming, and umbilical vein, or the vein that traverses in the liver. And this is the needle tip. I'm zooming the image. And then this is okay. So now the fetus moves in between also. So we need to adjust it. And then after adjusting, we see goes in. And then we see how it's being, the stellate is taken out. And sample is taken out, and then followed by starting the transfusion. So at the end we take out you see, this is what is the amount of ascites, the pleural effusion the patient has got. And in between I'm trying to see the fetal heart. What is the fetal heart? Such a anemic baby must be really very, very anemic. And if everything is going normal or not. So we take okay, so the heart rate is monitored in between, and then transfusion is continued. So this is how the transfusion is done. At the end of it, so it's still continuing, and at the end of it we take out the needle. And sometimes there is the needle is taken out, and see the amount of this thing, ascites, and this fetus has got. So the complication, naturally this process is not without any complication. It could have cord hematoma with atrial vasospasm and fetal bradycardia. Fetus may die during this procedure, premature rupture of membrane and initiating the labor. It can cause infection. Augmentation of maternal alloimmunization may occur, and hence the need for doing it at the same go, sampling and then transfusion. And long-term consequences of transfusion are not very discouraging. They are encouraging. One should do it. After first transfusion, how do you calculate? As I said, that at the end of the procedure, we sample again one hematocrit. And depending on that hematocrit, we decide when to be transfused again. So hematocrit decreases 1% per day. Suppose we have and transfusion to be given when hematocrit is less than 30. So if suppose we have got achieved a transfusion of 45, then 50 after 15 days it will be 30. So the next transfusion is planned, say around 20 days. So 45 minus 20 becomes 25. So at around 25, I will plan a next transfusion if she is not crossing 36 weeks. And delivery, depending on our neonatal setup, we also have to decide when to deliver. Any time after 34 weeks, say sometimes I have to do a transfusion at 36 weeks also, depending on what is our experience. Till date, we have crossed 1000 mark. So 1213 units till December 2024. And this is thanks to all the patients, all the staff present over here, all the resident, past, present, and in future, those who are likely to join me. So because of them, all this transfusion is possible. Earliest, this, because a lot of work goes on behind this transfusion. The procedure itself takes, say, half an hour, 1 hour, sometimes maybe 2-3 hours. But the behind the scene, the arrangement of O negative blood is a huge amount of task. If your volume is, say, 115, 125 in a year. Last year, we have done 128. Lowest hematocrit that we have transfused is 2.9. Knowingly, I wrote 3%. 2.9 is severely anemic, hemoglobin less than 1. So, but then baby survived. Maximum number of transfusion to a single fetus is 7. Survival is in high drops. We have survival of, say, around 60%, and non-hydropic, the survival rate is around 90%. This is what we advise. So we have a gupsup, coffee break. Yeah, we need a break. With all these transfusion, yeah, we definitely need a break. Yeah, yes. So we break for tea and then come back and then join. Yeah, yes. Yes, how do I differentiate between artery and vein? It is, okay, yeah, here. So if I zoom this, say for example, I've zoomed it. This is a larger vessel. This is a larger vessel, and nearby is an artery which is a smaller vessel. So artery is always larger, and vein is a larger vessel, artery is a smaller vessel. Next is, if you put your Doppler, then in a vein you will find a straight line. In an artery you will have, and if you are seeing the same caliber two vessel, then there are two arteries, one vein. So you will see two smaller vessel, one larger. So that large one is vein, small is artery. Okay. No, I do not give IV. I give it IM into the thigh, and I forgot to put a video of that. Into the fetal thigh, we give atracurium, actually, 0.4 milligram per kg body weight of the estimated fetal weight. So this is how the estimated fetal weight is calculated. And a few centers, they give IV. My experience is with IM only. And if it is an anterior placenta, I do not give. My initial 10-15 years, I never gave. Then subsequently, we have started giving it, but giving it IM only. And IM is, we see this thing, thigh, the lateral aspect of the thigh, and in the middle portion. But when I'm giving, I'm withdrawing, making sure that it's not in a vessel, and then injecting it, so that it doesn't go into a vessel. So femoral vessel is identified and then given. It's usually targeted. That is done before the starting of intrauterine transfusion. Yeah. High drops. GOK. God only knows. There is no, the fact is that the textbook says that after how much hematocrit you can increase. The textbook says that you can double the pre-transfusion hematocrit. That means suppose our pre-transfusion is 3, I can go up to 6 as per textbook. Can I expect anything to change from 6? That means hemoglobin of 2, nothing. In practically, we try to go up to 30. 30 means hemoglobin of 10. The hydrops resolves only if the hematocrit goes beyond 30. If the hemoglobin is less than 30, the hydrops will not resolve. So our target is, if everything is fine, we calculate the blood volume and the maximum volume that a fetus can tolerate. The maximum volume the fetus can tolerate is, how it is calculated is, where is, Dr. Malti can tell, divided by 20, or it is, what is the principle of it? Mechanically you people do. No? You understand it. So what is the principle is, estimated fetal weight, it's 10% is blood. So 10% becomes, say, 1.5 kg, 1500 gram, 150 is the blood volume. And maximum, I can give half of it. At a particular time, I can transfuse someone the half of the blood volume. That becomes 75. So we will not, in a 1.5 kg, I do not cross beyond 75. So 75 ml may increase up to, say for example, in a baby, it can increase up to say 35, 36. If it is, I'm crossing 30 hematocrit, that means hemoglobin 10, then I expect the hydrops to resolve. It resolves after second transfusion. It may require 4 or 5 transfusion and then resolves. It may be 1 transfusion. If I'm reaching 45, then it may resolve early. So it depends on what is the spleen size of the fetus, what is the hepatomegaly, splenomegaly. They destroy in liver and spleen, and depends on how severe it is. And what is my post-transfusion. If I'm crossing 30, then I'm very happy that the ascites will resolve. Once ascites is resolved, then the outcome is good. The baby will have a good outcome. At least I expect that. Till that time, it's very difficult for a baby to survive with fetal hydrops delivery, and specifically when preterm. Then next we have a cup of tea and then come back. Next, subsequently, so we had one is RH negative, non-isomanized, no antibody, 4 weekly, antenatal prophylaxis, postnatal prophylaxis, delivery at 40 weeks. Next case was RH negative, ICT positive. We continue 2 weekly, less than critical. We deliver her at 38 weeks. Next case was RH negative, less than critical. While monitoring, we saw that it reached up to critical and we deliver her at 36 weeks. Next patient was more than critical to begin with, and then we did a fetal transfusion and survived. And in that case, we monitor with MCA PSV. So once it reaches more than critical, we monitor with MCA PSV. We do not go ahead and do a titer. So if that is clear, probably RH is done. So our subsequent discussion will be on rare situation, like if a patient goes on bleeding, if there is some IUD, then if there is twins, last is the twins, then how do we, see, in that last patient of hydrops, they did a NIPT, whereas they did not do a ICT. ICT is simpler than doing an NIPT. See? So this is probably where I feel very sad about the management of RH isomanization, but let's put our heart and brain together and then do it. Okay, so let's break for a tea. And then, of course, we will wind up in next half an hour, 1 hour, half an hour, or no tea. We continue, no tea. And anyone who wants a cup of tea? Okay, so we continue and then finish it early so that we can, because those people who have joined are from outside. So and I invite Dr. Monali, who is behind arranging all blood these days. So she gets scolding from blood bank, she gets scolding from patient, and she gets scolding from department. I should not say me, but from the department. So sometimes she gets confused whom to follow. So in that process, but at the end of the day, we get a packet of blood and then we do transfuse. So we continue with the next case. Thank you.
Thank you, ma'am. So we will be looking after the interesting cases now. So she's a Mrs. X, 33-year-old, second gravida. Her blood group is B negative and husband's blood group is A positive. So in her first pregnancy, it was a spontaneous conception. It was a missed abortion and she did not receive injection anti-D. In second pregnancy, again, it is spontaneous conception. ICT was done and it was negative. But now she has history of on and off bleeding per vagina, which was at 13 weeks, 18 weeks and 24 weeks. And at each episode, she had received injection anti-D. And then she was referred to us at 28 weeks with ICT positive. So when we repeated her ICT, it was positive with us also, and it was titer 1:2. After 2 weeks, we again repeated, it was 1:1. And now the patient is still there. It is ongoing pregnancy. She is now at 34 weeks. So question is, in this case, when she was already referred to us at 28 weeks ICT positive report, should I give her? The answer is no. We should not give, because it is already positive and titer is also there. And the second question is, should I do MC-PSV now? No, no, no. Ma'am, the titer was, see here, the titer was 1:1 only. It is not critical titer. So there is no need to do repeat, there is no need to do MC-PSV monitoring. Should I deliver her at 36 weeks? No, because we are considering her as non-isomnized, not isomnized pregnancy. Should I do fetal transfusion? Definitely no. So, as we know, the half-life of anti-D is around 70 to 22 days. So, whenever there is recurrent episode of bleeding in subsequent weeks, the anti-D should be administered at the interval of 3 weeks. If we don't have a facility of ICT being done, we can repeat the injection anti-D at the interval of 3 weeks in case of recurrent bleeding. But if we have doubt and we have facility of ICT, we should get it done. And if ICT is positive, no need of anti-D. It means that the female is having those antibodies still in her blood, which will be protecting her. And if the ICT is negative, then anti-D has to be given. So, and after 20th weeks, the volume of feto-maternal hemorrhage must be determined if it is available. So, the gist is, whenever the systemic antenatal immunoprophylaxis is given, even if the previous immunoprophylaxis has been given in the preceding weeks, because of events that could cause immunization. It means even if we have given the patient injection anti-D for prophylaxis at 28 weeks, but if still she is having bleeding, it can be given. In the same way, the sensitizing events occurring after the administration of systemic antenatal immunoprophylaxis should be managed with additional dose of anti-D and an evaluation of feto-maternal hemorrhage. For the practical purpose where we are not able to do feto-maternal hemorrhage, and given the benefit of giving injection anti-D, we should give anti-D. But if we have facility of ICT and titer, we should do it. If it is positive and titer is there,
So there is anti-D, the effect is there and there is no need to give anti-D. We are there, we have it is in further discussion. The second case, a 28-year-old second gravida, her blood group is A negative and husband's blood group is B positive. ICT at 28 weeks is negative. Antenatal anti-D prophylaxis was given. At 32 weeks, she came to us with bleeding per vaginum and we made a clinical diagnosis of abruptio placentae. On ultrasound, we found that it was an intrauterine fetal death with retroplacental collection. Her coagulation profile was normal. Induction of labor was done and she delivered vaginally. And we found there was a retroplacental clot of around 450 cc, which was suggestive of abruption. So we gave her injection anti-D 300 microgram, two doses intramuscularly at deltoid, each injection. So now we have to keep a look at how much number of doses we have to give. So be it a cesarean section, be it a twin birth, or be it a shoulder dystocia that is representing a difficult delivery, the dose is single, that is 300 microgram, which is equivalent to 1500 international units. In case of abruption with intrauterine fetal death, 2 doses can be sufficient, as I have already told. And if more than 2 doses, we give intravenously. And in case of intrauterine fetal demise, I want to tell that the anti-D should be given at the time of diagnosis of IUD. We need not wait for the delivery, and it is very important. Whenever you have diagnosed IUD, you immediately give injection anti-D to the patient. If we are giving IV injection to the patient, and it is important to note that the preparation should be suitable for IV injection. Maximum we can give 3 injections IV 12 hourly. And the effectiveness of IV as well as IM preparation is same. So we should note this. So as we have learned, indications for multiple doses is suspected large feto-maternal hemorrhage, as in cases of abruptio placentae, intrauterine fetal death with abruptio placentae. As we know, there must be a large feto-maternal blood loss that is causing IUD in abruptio placentae. And Rh negative women of childbearing potential receiving D positive or D positive blood products in emergency. So this is also an indication for multiple doses of injection anti-D. Now, quantification of feto-maternal hemorrhage can be done first, as we all know, by Claire-Bedke test, which is also known as acid elution test. The basic principle is that the fetal hemoglobin, which is present in the fetal RBCs, is resistant to elution to the acid, and so it will remain as red and as a RBC as it appears normal, but the adult hemoglobin will get eluted, so it will appear as ghost. So we have to count the normal appearing fetal red RBCs among those ghost appearing maternal RBCs, and we can calculate the amount, the fetal blood volume, by calculating those fetal RBCs present in the slide. The second method is flow cytometry, which is an automated method, and we have it is less available. Again, the rosette test, it is a qualitative measure where we count the rosette per low power field, and then we decide the dose which is to be given. So all these tests are not being practically useful being done. So another important thing, that in severely thrombocytopenic patients with platelet count less than 30,000, injection anti-D should be given subcutaneously or intravenously, because we can't give intramuscular here. So the summary which we learned in this special situation about the repeat doses which will be required in case of recurrent bleeding. Then 2 doses in abruption with intrauterine fetal demise, and IV route which can be given, but we have to check the preparation whether it is suitable for IV injection or not.
All babies born to Rh negative mother and Rh positive father are Rh positive? No. So my exercise of doing this Rh symposium, seminar, whatever is successful. So I go back home, have a good night's sleep today. So the answer is no. Great. So we move on to the next case. So probably this answer your question of recurrent bleeding. So if a patient bleeds, we do not have clear bed key. So we can't do a clear bed key. First episode of bleeding, we give an injection anti-D. Now the patient bleeds the next week. So what should we do? The ideal scenario is we do not give an injection within 3 weeks. But if the bleeding is huge, you are thinking that whether मैंने दे दिया लेकिन probably gluteal में दे दिया and the product was not good, no cold chain maintenance, please do a ICT. This ICT will be positive because you have given this injection. ICT is positive, hold on your anti-D. Do not give your anti-D. ICT is negative, you definitely give even if it is the next week. So the bleeding recurs in next week and the woman continues to be ICT negative, you can repeat the dose. But definitely, if it is beyond 3 weeks, any event that occurs, she has an IUD, she has a delivery, she has anything. And the reverse, she has received antenatal prophylaxis and then subsequently she bleeds. You have to repeat it. So any bleeding, any event, specifically in an antenatal situation, we see bleeding. So any bleeding, we repeat it. Yes, madam. Yes. Yeah, maximum dose, there is no maximum dose as such, but maximum dose in over 24 hours is 5 doses. And if a patient is requiring more doses, then 2 doses can be given IM, but beyond 2, it should be IV. IV and IM are equally effective, but what they say is the absorption may be less. By effectiveness, they are both of them are same. But because it will take long time to absorption, so you give IV. Yeah, you give IV and you give maximum in 24 hours, you can give maximum of 5 injection. And this. No, directly. In how much time? This is a very small, this thing, ampu. It's not that slow. It is not like IgG, immunoglobulin that we give. It is the anti-D injection that we give is very less amount, 1 ml. So we can give. So we move on to answering exactly this question. If the father is RH positive, if I put it, if the wife is RH negative, father is RH negative, can they have a RH positive baby? Social question. So this is a social question. Let's figure it out. Yes. Yeah, social question.
So in context of this question, we have our next case. This is Mrs. X. She is 35-year-old, a 4th gravida with previous 1 term and 1 preterm delivery with 2 living issues. Her blood group was O negative and husband blood group was A positive. Her first pregnancy was a supervised pregnancy and uncomplicated. However, she did not receive antenatal prophylaxis of NTD. She had a term delivery, baby was alive and healthy, and baby blood group was A positive. She was given postnatal prophylaxis but over gluteal region. Then in subsequent pregnancy, it was a missed abortion which was managed medically, and here also she was not given any NTD injection. In her third pregnancy, which was a spontaneous conception, when her ICT was done, it was found to be ICT positive with an antibody titer of 1:16. And thus she was referred to MRH department, and where fetal anemia was diagnosed on ultrasound with MCA-PSV. So subsequently in this pregnancy, she was given 3 intrauterine transfusions starting from 30 weeks onwards, and the baby was delivered at 36 weeks. The baby blood group was O positive and baby is alive and healthy. In her fourth next pregnancy, she was reported to us at 10 weeks of gestation, and here her antibody titer was already 1:512 from the beginning. So her pregnancy, which was a very high titer. So her pregnancy was monitored with MCA-PSV serially. However, throughout her pregnancy, the MCA-PSV, it remained below 1.5 moms. So we delivered her at 36 weeks, and after delivery, the baby blood group was done, which was A negative. So this is the pedigree showing A positive mother and O negative mother and A positive father, where her first two deliveries, the baby blood group were positive. First pregnancy, baby was fine, not affected, whereas in third pregnancy, the baby was affected and was given intrauterine transfusions. But in last delivery, the baby was A negative and was not affected. So here comes the concept of zygosity. If the mother is Rh negative and father is homozygous for D antigen, all the babies born will be Rh positive, and thus they will be at risk of effects of isoimmunization and fetal anemia. Whereas if the father is heterozygous for D antigen, then 50% of the fetuses will be negative and thus will not be at risk of fetal anemia, whereas rest of the 50% can be Rh positive, and only these 50% will be at risk of developing anemia and other complications. So here, if in the pregnancy, we can determine the zygosity of the father or the partner early in the pregnancy, then we can identify these 50% of the cases where we can offer the cell-free fetal DNA to determine the blood group of the fetus, and thus accordingly we can monitor and monitor the pregnancy in those where the baby is Rh positive and at risk. So the learning points from this case are that zygosity determination can help us in selecting which patient do not require follow-up and decide upon the fetal blood grouping. So for further discussion, I call upon the stage ma'am.
So this patient had a IUT in her previous pregnancy, and now subsequent pregnancy we went on monitoring. We thought after 30 weeks, when her last pregnancy, she received anti-D. At that gestation, I thought probably this baby is with a normal MCA-PSB. Then I thought this baby is probably Rh negative that we are dealing with. We asked them to, how do I then determine fetal blood grouping? How fetal blood grouping will alter my management? If the baby is Rh negative, when do I deliver? 48 weeks. 38 क्यों? 40. हाँ चलो 40 weeks. If the baby is Rh positive, then I think plan for a IUT because she has received IUT previously. So this is how it can help. It is not available, but still we thought that let's discuss it so that we have this idea. Anytime it is available in India, we can get it done. So RH, both RH negative. Baby will be RH. All, yeah, some. They are negative, means minus minus and minus minus. On both chromosome it is negative. So 100% baby will be RH negative. So parents negative, but be sure of your paternity. Next is RH negative, RH positive. Okay. Now the baby will be, mother is Rh negative and husband is say positive. So 100% will be positive. Then in that case, you think that the baby will be definitely is positive. You have this report with you. Now, if I have the facility to differentiate between these two, and I find that the husband is like this, then in that case, 50% will be positive and 50% will be negative. And hence the importance of doing differentiating between plus and plus minus, because the subsequent pregnancy management will be different. So same is if you have Rh heterozygous, 50% chance that the baby will be Rh positive, and in that case you can do a cell-free fetal DNA for fetal blood grouping and do the RHD status. So genetically, phenotypically, both of them are Rh positive. Your blood test will give Rh positive, but genotypically it is on both chromosomes, the D antigen is there or the D gene is present, and in plus minus, in one it is present and in another it is absent. That is why it is called as plus minus. Okay, and in minus or Rh negative, always it is both the D are absent. So this is to better understand. We did RH zygosity in India of 100 sample. What did we found? Our study says that 74% are plus plus in zygosity. So that is done in DNA, so 2 ml of EDTA. And if husband is plus plus, then all fetuses will be RH positive, and hence you need not determine the fetal blood grouping. You know that it is deducted that this thing. But when it is required, how we know the fetal RHD blood grouping? How can we know the fetal RHD blood grouping? Cell-free DNA, chordocentesis, CVS, amniocentesis. What is the answer? Chordocentesis नहीं कर सकते हैं CVS कर सकते हैं, ब्लड ग्रुप कर सकते हैं CVS से, amnio में कर सकते हैं, cell-free DNA में कर सकते हैं. Answer is, so the Kit Kat goes to me. All of the above. Who said all of the above? This is anyway. So of course the leftover Kit Kat goes to me. So this is answer is all. In cord blood, if you are taking out a cord blood, if visible and anything, you put a needle, take out the fetal blood and determine as you do in any blood group. So, but this is an invasive procedure. In fetal sample of CVS or amniocentesis, there are techniques to determine RHD only, not ABO. So, you can do D blood grouping on fetal sample that is obtained from CVS and amniocentesis. I have got a picture. Then cell-free fetal DNA is the latest, and it can determine, because mother is RH negative. As I showed that mother doesn't have any D antigen over here. So mother's DNA doesn't have this DNA, D DNA. So now any DNA in the mother. So I will take out a mother sample and take out plasma and cell-free DNA. In that, if I am identifying this D gene, then that is definitely from the fetus. So this is the principle of doing a fetal DNA, and that is being done in Western countries very regularly and as a routine practice in this thing. Not available in India as of now. There is one company who is promoting it. The cost is little high. The initial phase of the study was done by me only, but there is not adequate data to support it, that we do it, we jump on doing it, because whatever sample I gave, all the babies were RH positive, except one where the lab report was indeterminate. Because the lab report was indeterminate in an IVF pregnancy and the baby turned out to be RH negative, then, and hence the background of this validity of the study is not this thing, though the company has promoted it and then is selling it. I am not party to that, but it was done by our sample only. So RHD status of the fetus can be done from chorionic villus sampling and amniotic fluid. This was published in NEJM way back in 1993. I also did this study, and the test is not very complicated. It is restriction fragment length polymorphism. So it is a simple test. Then subsequently in 1998, Lowe et al., they found out fetal DNA in maternal plasma, and subsequently they proved that it can be used for determining fetal RBC. So from India, this was the study from PJ Chandigarh, and they also did this whether it can be done, and this is available in limited laboratory. That is why I have written that one lab is promoting it. The course is not a straight line always. RH negative, you do not see negative, then it is ICT negative, delivery at 40 weeks, antenatal postnatal prophylaxis, RH negative. It could be very difficult. What could be the causes of isoimmunization in a primary gravida? Yes, madam. One is history of blood transfusion, which was RH positive. Primigravida is not true primigravida, and which is more common now. Okay, very common, very common. So history of blood and blood products transfusion, antenatal bleeding, antenatal procedures, and previously we used to see that for sex determination, but this is reduced. But if nothing is there, the patient is a very reliable patient. Still she is ICT positive. It is grandmother's phenomena. That means when this woman was in her mother's womb, she got some RH positive. Mother can be plus minus zygosity. Husband can be plus minus. And now this minus comes into this fetus and she becomes minus and thereby she is RH negative. Now this RH negative fetus got exposed to RH positive cells from the mother. She got isoimmunized. So when this woman is becoming pregnant, she is affecting her fetus. So the relationship of her fetus to the grandmother, the blood group of the grandmother. So that is why it is called as a grandmother phenomena. And that is the reason why you must do ICT in a primigravida. So at the end of this session, if one learns ICT for all at whatever gestation the patient comes to your clinic, ICT is a must. So that is, can we do this thing ICT be in a twin pregnancy? How do I manage? RH isoimmunized in a twin pregnancy. See this patient. This is intrauterine transfusion being done on this twin A. You can see that the spine is this side and this thing is being done. And this fetus has got a spine on that side. So this is done again in hepatic umbilical vein route. And this was in 30 weeks 1 day. So we have done 30 weeks 1 day. And now husband is carrying, this is actually yesterday's picture only. The baby is still in NICU. The mother, the father is holding this baby who is with the mother. Like this baby is outside and with mother only, bedside only. But they are waiting for discharge of this baby to come out. The baby is off oxygen and doing well. So the twins can be continued and can receive transfusion on both twins. The story is not always that rosy of getting both the fetus. See this. One can appreciate fetal hydrops over here, twin gestation with a membrane and with a this thing. And we have, this is fetus, head, abdomen, and with a amount of ascites. And this is one fetus, then this is another fetus. So definitely there are two twin gestation with a dichorionic diamniotic. See this amount of ascites in this. So one is hydropic, other is less hydropic. We prepare 20 weeks, 3 days, DCDA twin gestation, RH isoimmunized. And if I tell you the story of this patient, the obstetric history, first pregnancy, she had a male baby diagnosed to have DMD. She took over-the-counter pill in 4 pregnancies, 4 MTPs. Yes. Then subsequent pregnancy, she was seen here in our department, met with a roadside accident, abdominal trauma, IUD, had to have a hysterotomy, 22 weeks, 23 weeks. And now with twin gestation, one hydrops, another is also MCA-PSB more, 20 weeks, 3 days. Luckily, she is not a carrier for DMD. Her previous child was DMD, but she was not a carrier of DMD, and hence these twins were not tested for DMD. That is a different story. But with all our best effort, we could able to arrange for a packet of blood the very next day. We planned for transfusion. At the point of transfusion, when we started, there was IUD of the hydropic twin. So now, just before transfusion, we noticed that there is no heart. of this hydropic baby. So we got the other baby that day transfused. This was that fetus. We got transfusion. Of course, the MCA-PSB was more, and we got this transfusion, and we did 6 transfusion to this baby. And see the smile on the face of this patient holding this one baby. And I always miss that the one which we could not. The pre-transfusion hemoglobin of this baby, this baby was 2.9. And this was like, must be, the other one must be less than that. And hence, probably IUD. So always twins, difficult situation. And but one should not lose hope. And what we are left with is, when should I do the monitoring of these babies? Madam says 18 weeks. Should I do 18 weeks for all patients? Patient comes from Patna, very, very far off. No. The answer is previous affection minus 10 weeks. So if you are very sure of previous affection, the patient is a reliable patient. He has previous ultrasounds, and that affection, affection means fetal death, hydrops, transfusion, delivery and requiring exchange transfusion. All these are affection. So previous delivery at 40 weeks and baby was affected, or 36 weeks, I start my monitoring at 26 weeks. If there is no such history, no reliable history, then I start monitoring, of course, from 18 weeks. But sometimes our smallest fetus is 18 weeks. So we, in a RH isoimmunization, transfusion can be done after 16 weeks. So we start monitoring from 16 weeks, though our MCA-PSB, the nomogram, is from 18 weeks. We can do that. So this is a summary of this today's session. We are dot on time, though we started late. Still, we wind up. ICT negative, 4 weekly ICT. Yes, I am after this JR because she's the only one. So, bolte na ki lote. So she's the only one. Yes, you read it out, bete. Stand up and then read it out. JR3, JR1, JR2. Okay. Oh, that's the best phase of your life. So you read it out.
If ICT is positive and antibody is less than critical, then monitoring is done 2 to 3 weekly and timing of delivery is 38 weeks. If ICT is positive and antibody is more than critical, if MCA-PSB is less than 1.5 mom, then timing of delivery will be 36 weeks. And if MCA-PSB is more than 1.5 mom, then you refer for intrauterine transfusion.
Done? Great. Thank you so much. Yeah. Now, any questions? We wind up. Yes. Yes, definitely. Okay. So the recommendation, if you look into the recommendation, it says that if it is a surgical abortion, then you must give any duration. If it is a medical abortion, less than 10 weeks, you should not give. And after 10 weeks, you should give it if it is a medical abortion. But in our condition, we are giving monoclonal. We are not very sure that the medical abortion will not turn into surgical abortion. So for us, all abortion, give it. That is practical. They say 50 microgram, then they have got 100 microgram because the pooled sera is less. So that is why they produce these smaller doses also. We do not have that. So we give, for all, we give 300. So for all, theoretical knowledge, for them to pass the examination, surgical abortion, all, medical abortion less than 10, do not give, more than 10 weeks, give. But practically, you give for all.